Good evening, Ashvini. And depending on where you are, good morning, good afternoon, and good evening, ladies and gentlemen. My name is David Kaiser, and I'm a Senior Scientific Education Manager here at Geistig Pharma AG in Switzerland. Together with my colleague Adam Raskatov, I'm responsible for the Webinar World Tour. It's a great pleasure and honor to introduce you to our speaker of this evening, Professor Dr. Ashvini Padhye. This evening, she will be talking about predictable and proficient management of deficient peri-implant hard and soft tissues, the key to long-term success. Professor Dr. Ashvini Padhye is a periodontist and implantologist who is based in Mumbai in India. She received a Master of Dental Surgery in Periodontics from the Governmental Dental College and Hospital. She's director at the Dr. Padhye Dental Surgery Centers in Mumbai. She's founder, director, and course conductor at Recreate Regeneration Academy, which trains clinicians through specifically created courses on bone and soft tissue regeneration, perioplastic surgeries, and various topics in implantology and periodontics. She's currently a professor at the Department of Implantology at the Mahatma Gandhi Mission Dental College and Hospital in Navi, Mumbai. She's a fellow of ITI and has over 40 international and national publications in peer-reviewed journals with more than 624 citations. She has a H index of 11 and an I-10 index of 12. Thank you very much, Ashvini, that you agreed to be part of this year's Webinar World Tour. I give the word to you now.
Thank you so much, David, for that kind introduction. And it's an absolute pleasure to be here with all of you. Greetings from Mumbai, India. I'm very honored and privileged to kickstart the Geistlich World Webinar Tour 2023. And I look forward to the next 1 hour of a truly interactive session with each one of you here. And thank you for joining in. So when we are looking at implants and doing implantology in everyday practice, what we are striving to do is not only placing implants. If you ask me, placing that implant happens to be the easiest part of the whole surgical procedure. What we are striving to do is creating that perfect balance of hard and soft tissues around those implants to mimic or depict or replace the lost structure and function of that tooth in the patient's mouth. May it be a single tooth or may it be multiple teeth. So we are striving to take each of our cases from here to here, or a single missing lateral incisor, which is badly broken down, to here, or two adjacent central incisors where you need to depict that exact architecture of the contralateral tooth into this tooth, or periodontally involved teeth like this, which becomes a big dilemma in patients who are young and seek absolutely good aesthetics at the end of their treatment. Titanium tattoos with thin bones on the buccal aspect, how do you take them from here to here? Or lateral incisors in a young 22-year-old girl from here to here, and as well as two central incisors here. Laterally missing, congenitally missing lateral incisors in a girl who's 21 years of age, and how do you give her smile back and make that beaming smile back for her? Or then full mouth prosthesis, where you have patients with absolutely terminal dentitions, which cannot be saved, which have systemic diseases at their background. How do you take a patient from here to here or here to here with so much of hard and soft tissue loss? So every Monday morning when I go to practice and I have a patient who's coming for implants and my back team at the office tells me that, okay, there's a patient who wants implants. What are we hoping for? We're hoping that this patient comes in with absolutely good bone, good soft tissue, good vertical dimension, no loss of tissues. And then it's such an easy case. It's better than the back of your hand. You know how to go ahead with these surgeries with simple guides, simple stents like this, which give you to place your implant in the perfect prosthetically right position. And you go ahead and place your implants in stable bone, which is bleeding, with good bone on the buccal, good bone on the lingual. You have a good tissue phenotype to support those implants. So you place your healing abutments and you go back after 4 months. And what do you see? You see beautifully healed tissues. You see beautiful gingivae around the implants, and you have a nice cuff and collar to go ahead and then place your final restorations with your laboratory, giving you a nice ovate pontic and an emergence profile, even to those posterior teeth. And this is what we are all dreaming of, but only if dreams could be horses, we would all be flying. Reality versus illusion. Every day in practice, what are we put up against? We are put up against various scenarios in clinical practice, which are so challenging that you wonder at times, how do you restore the hard and soft tissues back for each of these scenarios? From simple teeth which are broken down to huge vertical defects like this or like this in the posterior mandible. And how do you take each one of this, not only functionally, but also aesthetically, to give the patient the final optimal outcome in the cases that you're going to plan? So what are the endpoints of success that we are looking at? We are looking at duplicating the natural lost tooth form and function, both function as well as aesthetics, harmonious gingival margins, intact interdental papillae. You don't want dark triangles in between the restorations that you're giving your patients, and a nice convex contour of alveolar bone with the soft tissue profile to support those implant restorations. Peri-implant aesthetics in the anterior zone especially depends on the soft tissue and depends on the bone. Now, the soft tissue, peri-implant soft tissue, basically depends on two bone structures that you have. One is the height of the crest of the alveolar bone of the adjacent teeth or the adjacent ridge. Where is the peak of your bone of the adjacent areas? And second is the thickness and the height of the buccal alveolar bone that you have, because this buccal bone is going to support the soft tissue on top of it. So if you don't have bone, you are not going to be able to get the soft tissue to support and give you the emergence profile to your restorations. So when we look at implant aesthetics, there are basically 5 diagnostic keys that I would look at before I go into planning that case for placing the implant. It depends on the tooth position, how high or low is the tooth in the arch, apicocoronally. So more coronal or more lingual, that means the tooth is having a lot of buccal bone. It is having no soft tissue or buccal bone loss, as compared to a tooth which has recession or a high bone level, which becomes a further challenge because you're dealing with a hard and soft tissue deficiency. Typically, these teeth will come with a flatter scallop, the ones with a higher profile, as compared to the teeth with the recession, which will come with a very high scallop gingiva. The biotype or the phenotype around these will be thicker compared to a thin biotype around the high risk patients. Tooth shapes will be more square in the low risk patients and more triangular in the high risk patients, as well as the osseous crest position, like I said before, will be higher in the high risk patient as compared to the one which is be closer to the gingivae and no soft tissue or bone loss in the low risk patients. So the outcomes that you plan for these patients are going to depend on these 5 characters, especially in the anterior aesthetic zone when you're looking at planning implant cases. These are the ones which will give you a very favorable outcome without much of extra surgical intervention that you would need to do, as compared to the ones which are a high risk, where you need to give yourself a thinker before you plan that case as to the additional surgical procedures that you may need to put all of that in place. So let's look at implants in various scenarios that we do in clinical practice. So I'm going to be starting off with immediate implant placements and what you need to do when you're doing immediate implant placement. So when you look at extraction sockets or implant placed in extraction sockets, the final outcome that you are going to get or the procedures that you need to do depend basically on the amount of hard and soft tissue you have in and around that socket when you are planning that case. So typically, you can classify extraction sockets post-extraction into 3 types of scenarios that you would come across. The type 1 socket is where you have no buccal bone loss, neither do you have any soft tissue loss. So you have a pristine tooth, which is the patient has probably had a fall yesterday, fractured the tooth, and you need to remove that tooth and place an implant. So it's a pristine socket. The type 2 socket is where you have a buccal bone deficiency, but you do not have a soft tissue deficiency. Now, this buccal bone deficiency could vary anywhere from 0 to 5 millimeters. We will talk about how we deal with each one of them. And the last is a type 3 socket where you not only have buccal bone loss, but to complement that, you have buccal soft tissue loss as well. There's a direct algorithm that I've made for you, which you can categorize the sockets that you're looking at post-extraction. So if you are in a type 1 socket, which is a pristine socket with intact buccal bone and no soft tissue loss, with a thin phenotype, in that case, that is an ideal case to go ahead and place an immediate implant. You go ahead, place an immediate implant, provided you get an implant stability of 45 Newton centimeter or more. Whenever you place that immediate implant, these are the sockets where you want to maintain the buccal bone, the soft tissue, and all of that. So these sockets, after the implant placement, you do a dual zone augmentation where you augment not only the zone up to the crest of the bone, but you augment the zone right up to the crest of the soft tissue with a slow resorbing and organic bovine bone mineral, which is what holds up the soft tissue as well as the bone and prevent the jumping distance from collapsing, because you want a jumping distance of more than 2 millimeters to maintain that buccal bone and soft tissue. And once I've done this, this has to be supported by an immediate provisional, which is sculpted and shaped in order to develop the soft tissue, hold the soft tissue, support it, and recreate what you've lost. All of this will remain the same if I have a thin biotype, except if I have a very thin phenotype, I might look at a phenotype or a biotype conversion with a soft tissue graft or a 3D collagen matrix substitute, which can be used to thicken the biotype in that case, because we have all seen through all various studies that a thicker biotype or a thicker soft tissue is necessary for maintaining the bone underneath the soft tissue to maintain your implant in pristine health. If we are in a type 2 socket, which is a buccal bone loss ranging from 0 to 5 millimeters, then in that case, depending on the bone loss, what I mean here is if I have a bone loss of 0 to 2 millimeters, I would still go ahead, place my immediate implant and do a socket augmentation with a dual augmentation for those 2 threads of the implants which are exposed. If I have a defect up to 5 millimeters, I can still go ahead and place my implant, provided I get the stability from the palatal and the apical bone that is present in that socket, and go ahead and do a dual zone augmentation. Now, in this case, if I have a loss more than 0 to 5, like 5 millimeters, I would not go and provisionalize that tooth. In that case, I would make a customized healing abutment, because that is still maintaining the soft tissue contour of that socket, and it's going to develop with maintaining the soft tissue profile. In a type 3 socket where you have buccal bone loss as well as soft tissue loss, and the bone loss is more than or equal to 6 millimeters, that is not a site to go ahead and place an immediate implant. That is a site which will need first a site preservation. So it will need probably a 2 or a 3-stage approach to implant placement. So it would need to start with a site preservation with a dual zone augmentation and closure. Then you go in and do a site development. If you can place the implant at the same time and do a site development at the same time, you can go ahead and do it. Or otherwise, you do a site development, augment the bone. You have now the soft tissue to cover the bone, grafted bone. And then after 6 to 9 months, depending on whether you've done a horizontal or a vertical augmentation, you go ahead and place your implant and provisionalize that implant to sculpt your soft tissue. So let's look at different clinical scenarios of type 1, type 2, and type 3 sockets of how this can apply when we are doing it actually in practice. Before we go on to looking at a case, a very important factor that you need to consider is how you shape your provisional, because that provisional is the one which is going to actually shape your soft tissue and create that soft tissue contour. So there's a very good article given by Huan Su et al., which talks about the critical and the subcritical contour. So the critical contour is the part of the provisional restoration or even your final restoration, which is 1 to 2 millimeters apical to the gingival margin that tooth is supposed to have in the future. So it typically will match the gingival margin of the contralateral teeth, and that critical contour should always be convex to support your soft tissue or the gingival margin like a cuff on which your restoration is going to sit. The subcritical contour is the contour of the restoration from below the critical contour up to the head of your implant. Now, this is the contour into which you want the soft tissue to actually grow to create that emergence profile which you have in a natural tooth. So depending on this, there's a very good algorithm for the profiles given by Stephen Chu Chen and co-workers to tell you how your critical and subcritical contour should be. So typically we talk about critical contours, which normally should be a convex contour, unless you have a tooth which is extremely lingual in position. And the subcritical contour on the facial side should always be concave or flat, because only then are you giving enough running room for your soft tissue to mature and create an emergence profile to that restoration. The same applies to your interproximal areas as well. In the interproximal area, you want the subcritical contour from the head of the implant to your critical contour to be either concave or flat, but not convex, because the moment you make it convex, you're going to push the soft tissues away, and getting that papilla back is going to be a big challenge. So how you develop your provisional restoration is going to finally give the blueprint of how your final restoration gingival contours are going to be. So let's look at Nikhil, who came in with a type 1 socket. He had a fractured lateral incisor, which needed extraction. So once you go ahead and do an absolutely minimally traumatic extraction of this, because what you are aiming to do here is preserve every 0.00001 millimeter of bone that you have in and around that socket. So you don't want to lose any bone while doing the extraction. So once you've extracted the tooth and you have a nice pristine socket present over here, you cure it out the socket well. Once you've cured out the socket to make sure that it's absolutely degranulated and you have no soft tissue remnants remaining in the socket, you go ahead and place your implant in the perfect three-dimensional position. So this is the implant in place, which has primary stability from the palatal wall as well as the apical bone. And that's the final implant position. Once you place the implant, now this is an implant which has 45 Newton centimeters. So I'm going to go ahead and make a provisional restoration for it. But before I place the provisional restoration in the patient's mouth, I am going to do a dual zone augmentation because I want to graft this jumping distance as well as the zone right up to the soft tissue collar, so that this anorganic bovine bone mineral, which is slow resorbing, is going to hold that tissue upright and maintain the soft tissue contour of that socket like it was in the natural tooth. So once you've done the dual zone augmentation, you go ahead and give a screw retain immediate provisional to this patient. Once that is done, the patient comes back after 3 months, and that's the beautiful profile that you get. Now, these particles that you see are the particles of the bone mineral that you've added, but these are only holding the tissue up, and they will resorb over a period of time. But by then, your soft tissue has completely formed. So this is the kind of profile that you want to see in these patients once they come back to you. And then you go ahead and pick up a customized impression. It could be digital or analog. And that customized impression is going to let the lab replicate and fabricate the final crown to mimic this critical contour as well as the subcritical contour that you have given the patient in the provisional restoration, so that they can absolutely mimic the soft tissue contour that you've created in the patient's mouth. Once that is done, that's the final restoration in place. You have well-stippled gingiva, you have good interdental papillae, and you have an absolutely stable margin of buccal soft tissue. That is how the patient reported at baseline. And that's the final smile of the patient once the restoration was given in place. Now, this patient has a medium lip line, so he is showing these papillae. So when you recreate this, you want that these papillae are absolutely intact in the patient's mouth. And that's a 5-year follow-up where you see that the bone is absolutely well maintained above the crest of the implant. And that's the smile of the patient at a 5-year follow-up, showing that the soft tissues are absolutely in place in those areas as well. That was talking about an anterior tooth. What happens to posterior teeth, premolars or molars, when we are having teeth to extract? Does aesthetic only count in your anterior zone? No, we're looking at replicating the bone and soft tissue even in the posterior zone. So let's look at Shubhangi, who came in with a completely mutilated 2-5, the second premolar in the second quadrant, and she needed an extraction of that. So are these also sockets for immediate extraction? Absolutely. Whenever I have a pristine socket, even in the posterior region, I would go ahead and place an implant engaging the palatal wall. So today, to do these osteotomies, I use the osteodensification because they do help very well to create your osteotomies. And that's the implant in place. Now, what happens? Am I going to give an immediate provisional on this? No, because you don't want to load the posterior implants because there are a lot of occlusal forces coming on these implants. So what we do for these implants is you give a customized healing abutment, which will maintain and hold your soft tissue profile in that restoration. So once the implant is in place, you put in a temporary cylinder and you make a customized healing abutment with flowable composite. So that's the flowable composite put in place, which is cured. And once you have picked up the soft tissue profile, you remove it from the patient's mouth and you polish it, finish it again to sculpt and give a concave profile so that you have the emergence profile recreated back when this heals. The rest remains the same. You do a dual zone augmentation. and you put in the customized healing abutment in the patient's mouth. And that's the final customized healing abutment. And the patient remains with that. That's the X-ray immediate post-operatively once the implant has been placed with the dual zone augmentation and the customized healing abutment seated. And when the patient comes back to you after 4 months, you have a beautiful collar of soft tissue. Another thing that is the advantage of giving these customized healing abutments is if you try to close sockets, you are going to advance this buccal soft tissue, causing a movement of the mucogingival junction, landing up in decreased width of keratinized mucosa in your final restorations. So this maintains entirely the socket and the keratinized mucosa with the buccal profile because you've not raised a flap. You go flapless in these cases. So that's the beautiful profile that you create in these cases. And that's the before, and that's the final restoration in the patient's mouth. So you see there was a loss of the distal papilla, which you could recreate because of your customized healing abutment and give this to the patient. That's a 6-year follow-up. Absolutely stable bone, absolutely stable tissues. And that's a 6-year follow-up of the restoration where you have the mesial papilla, distal papilla, and a beautiful buccal contour to support that restoration, which has been put in place. So for premolars also, you follow this. And what do you do for immediate molars? Now, immediate molars, the placement of an implant in an immediate molar site is governed or dictated completely by the amount of interradicular bone that you have. If you have well-divergent roots, the immediate molar sockets are absolutely indicated for an immediate implant placement. So there is a type 1, type 2, or a type 3 implant placement when it comes to immediate molars. The type 1 is when you place your implant in the interradicular bone and you have bone surrounding it from all sides is the native bone. Type 2 is when you have some parts of the implant in native bone, but the rest is in a jumping distance. And type 3 is when you place a wider body implant to engage the socket walls of that socket. So let's look at a type 1 molar placement, immediate molar placement. Mr. Pramod came in with a vertical fracture of the 3-6 tooth in question, was the molar, the first molar in the third quadrant, 3-6 vertically fractured. So extracting these teeth is very important in the right way because you do not want to lose this interradicular bone because that is where your implant is going to go and sit down finally. So you want to maintain that. The best way to do it is section your teeth if you need to and atraumatically extract those teeth. Once you've extracted it, the protocol remains the same. You degranulate your sockets and you find this island of interradicular bone that is present there. Now, the center of this island is the center where your implant needs to go and your implant trajectory, because that will coincide with the central fossa of the future prosthetic restoration that you're going to give this patient. So once you've done your osteotomy preparation, you see that there is good bone on all sides of the socket. I use the densification to do this because that ensures that your socket remains intact. And once the implant is placed, I'm going to again make a customized healing abutment because I, for no reason, want to advance this soft tissue and lose the keratinized mucosa and the soft tissue profile. So once I have an implant stability of 45 Newton centimeter, these are some silicone indices that you get. You get them in India. I don't know whether you get them there, where you can actually just put in your flowable composite to create a soft tissue profile of that molar. So that's how it comes out, where you have nice convex profiles in the interdental areas and on the buccal and the palatal areas. And once that is done, you check the fit of the customized healing abutment. You know it's seating completely. You remove it out, place a cover screw. Make sure that you don't forget to place the cover screw because you don't want any particles of the anorganic bone mineral going into the implant internal hex, because otherwise then you'll have a problem seating your abutment. So once you've done that, you gently remove the cover screw and replace it with this customized healing abutment. If you feel that the margins or some papillae have deflected slightly, you could just go ahead and place 2 sutures, mesially and distally, to hold the whole thing together. So you see that this customized healing abutment, along with the soft tissue, forms a watertight seal to hold the graft material which you placed underneath on the implant. And that is all going to heal beautifully. So when the patient comes back at 4 months, this is what you have. And when you remove the customized healing abutment, you see you have a beautiful replica of the socket which was there before you even started and extracted that tooth. Now you go ahead and pick up customized impressions. And that's the final crown in place, where you have a nice scallop, mesial papilla, distal papilla, and absolutely pristine soft tissue around that tooth. So that was baseline. That's the radiograph post-operatively, where you see the sockets have filled up beautifully with that anorganic bovine bone mineral. In this case, I've used Bio-Oss. That's what holds and supports the bone as well as the soft tissue. And that's the final restoration in place. So before and after, with absolutely healthy soft tissues around it. Now, these are all sockets that we've spoken about, which are type 1 sockets. What if you have a socket which is type 2 or type 3 socket where you need soft tissue or hard tissue augmentation? So let's first talk about soft tissue augmentation that we do in clinical practice around implants. So there are two scenarios where mainly you would need to do soft tissue augmentation around implants. The first being to expand the mucosal volume to attain a natural cosmetic drape around the implant. That means you have deficient soft tissue or you have a thin phenotype and you want to thicken the phenotype so that you can give your restoration and emergence profile on the buccal aspect. So from here to here with the soft tissue augmentation, you have enough soft tissue now to sculpt it for your restoration. And the second and one of the most ignored parts in implant dentistry is to increase the width of keratinized mucosa. So I'm going to talk a little in depth on increasing the width of keratinized mucosa because that plays a very important role in the long-term stability of your implants in function. When you look at keratinized mucosa, that is like these implants are ready to be loaded with a restoration. Now, how many of you really think that these implants are going to survive once you get your occlusal loads on these restorations? Impossible. It's a sure shot recipe for failure because there is no keratinized mucosa to support these. Or look at these implants, which are placed with absolutely no keratinized mucosa, or implants like this. So how do you first stabilize this zone? Because this is the most important zone. Otherwise, when you have a deficient keratinized mucosa, every time the lip or the cheek of the patient moves, which is 10, 100 million times in a day, you are going to have a deflection of the soft tissue away from the implant surface and your abutment surface. This deflection is going to cause plaque and other biomaterials to go in and get embedded in that peri-implant sulcus, leading to perimucositis, peri-implantitis, and implant failure. So attaining a good zone of keratinized mucosa is of most importance. Now, whenever we talk about soft tissue augmentation around implants, we have various soft tissue graft procedures that you can do. You can do a free gingival graft, a subepithelial connective tissue graft. You can do a VIP CT or a bifid VIP CT for mesial and distal papillae. These are all autogenous soft tissue grafting procedures. Today, we have at our disposal 3D collagen matrices, which are absolutely form stable. And Geistlich has some like the mucograft and the Bio-Gide, which are beautiful materials to use instead of a autogenous soft tissue graft procedure, especially when you need it in larger quantities. So we'll be seeing a case where I have used this material. So first, let's look at a type 1 socket with a thin biotype. So Manisha came in. Now, this patient was a very tricky patient because she happens to be the mother of a dentist. Now, when you're treating a mother of a dentist, you already have your, all your alarm bells up. You want to do the best that you can because you're under a scanner when you're treating these patients. So she happens to be the mother of a dentist who had this broken down lateral incisor, the 1-2, and she was wearing this composite buildup. It was a root piece which was remaining inside. And I looked at the case and I said, okay, fine. This is a case where I want to go in and place an immediate implant because the bone was at the right level. There was no bone loss, but the soft tissue was a little compromised. So did an extraction, went ahead, ascertained my buccal bone position, which was at 3 millimeters from the crest of the gingiva, and went ahead and placed my implant with an immediate provisional fabricated chair side to give the patient. And she walks out with this provisional in her mouth. And she comes back 4 months later. Everything looks very good on the buccal aspect. But when I look at it from an occlusal aspect, there's a huge deficiency that I see over here because there is no convex contour of this soft tissue over there. So though there was no bone loss, the soft tissue being thin and inflamed, there was a lot of tissue shrinkage around this tooth over here. So I decided to go ahead and do a partial thickness pouch to augment the soft tissue. So whenever I would do this, you create a partial thickness pouch in the connective tissue over here. You don't need to raise a flap, just a pouch is enough. And you put in a connective tissue graft into that pouch, which will thicken that soft tissue there. So what I use is a microsurgical blade. Now, one mistake that I made here, which I want to bring to your notice is whenever you're creating these pouches, remain as close to the bone surface as possible, especially in thin biotypes, because otherwise you'll land up perforating this outer surface of your epithelium, which is not what you want to do. So you create a partial thickness pouch, that's the pouch created. And I went ahead to the palate and harvested a subepithelial connective tissue graft, that's subepithelial connective tissue graft. And then with a single sling suture, you sling that connective tissue into this pouch. Now you see here that perforation got perforated once I passed my connective tissue in. Nevertheless, if 70% of your connective tissue is still in the connective tissue pouch and protected by connective tissue on both sides, you will still have that graft be taken up. Once you've done that, you place the provisional back, you create the contours that you want, and you reshape the provisional and place it back in the patient's mouth on that same day. And then you let this heal for a period of at least 3 months. And you see from here to here is the convex contour that you can get. And you see the thickness of the soft tissue on the buccal aspect after this augmentation procedure that has to be done. And that's the final profile, that you get a nice convex contour of the socket. And then you go ahead and make your final restorations with customized impressions, which the lab replicates. That's the final impression in place. And you have good, thick, soft tissue to support that restoration in place. That's the occlusal view, where you know that you have good supported tissues, you have your restoration in the right position, and that's the radiograph. Now, when this patient came to me and I took this first picture, I was pretty telling myself that, okay, you don't need to sweat. She has an absolutely medium or a low lip line. She's not even showing that gingiva. So, some mistakes here or there can be pardoned even if you're not doing the right thing. And I was more so alert because she was a dentist's mother. When she comes back a year later, this is how she smiles. So I said, okay, she's got a little bolder probably, and the smile's gone slightly higher. And then when she walks into my office 8 years post-operatively, she is beaming molar to molar, showing not only white, but a huge amount of the pink. Now, smiles like this are the ones that we need to be very careful with, because the smallest of discrepancy or the smallest of problems that you have in this is going to completely show when that patient smiles. So what do we have at the end of 3 years, at the end of 8 years? We have good, stable soft tissues, mesial papilla, distal papilla, and buccal contour of the soft tissue, which is absolutely stable because the bone underneath is stable because of all the steps that we followed in doing this case to the start to the finish. So to sum it up, what are the key steps that you need to look at when you're looking at immediate implants? First is you need to do a minimally traumatic extraction. You cannot do an extraction which is atraumatic, because an extraction by itself is a traumatic procedure. You degranulate the socket well to remove any soft tissue remnants present there. You ensure the presence of a buccal wall. If that's not there, you need to augment the buccal wall, which is missing. The three-dimensional positioning of your implant is an absolute necessity to get the profiles that you want in the hard and soft tissues when you're doing immediate implants. Dual zone augmentation if you're placing a customized healing abutment or an immediate provisional. A tissue biotype conversion, if you had a thin biotype, you convert it to a thick biotype. Immediate provisional or a customized abutment to support your tissues. Customized impressions, lab communications, and delivery of the final crowns. So these are the key steps that you need to follow when you're looking at immediate extractions. Let's move on to another very favorite of my topics, which is how much of keratinized mucosa is enough, or how much attached mucosa do we need around implants for them to remain in health at all times. Enough and many studies have been done on this, and we have landmark studies who have told us now and come to a consensus that you need at least 2 millimeters of healthy keratinized mucosa around an implant for it to remain in health for a long term. And this can be achieved only by augmenting it if you have a deficiency to start with. So when we look at augmenting the keratinized mucosa, earlier, though free gingival grafts are one of the most gold standards to augment a band of keratinized mucosa, the biggest problem with free gingival grafts is, A, they become very traumatic to the patient because you're leaving behind a huge area of raw surface from where you're harvesting the graft from the palate. So that becomes very painful for the patient. And secondly, if you need a lot of material, like if I'm doing a whole arch of keratinized mucosa augmentation, where am I going to get so much of free mucosal grafts from? So there becomes a dearth of the amount of material that you can get for this. So what I do is the epithelial strip technique in combination with a 3D collagen matrix, which gives you a very stable zone of keratinized mucosa. So let's look at Kusum, who came in this was a preoperative situation. She had a failing maxillary dentition, and she had 2 implants placed in the mandibular arch on which she was wearing a removable implant supported prosthesis. She was very unhappy with that, and she wanted a fixed solution to this. And these implants were failing. There was already bone loss around these implants. So I decided to go in and do an all-on-4 protocol because if you see in this patient, she has bone in zone 1 and zone 2 in both the maxilla and the mandible, and deficiency of bone in the posterior zones in both maxilla and mandible. She was 75 years of age, so decided to do the all-on-4 protocol for her. So that's the mandibular implants which were failing. So explanted those implants and made new osteotomies to place 2 tilted implants in the posterior zone and 2 axial implants in the anterior zone. Typically, when you do these full mouth cases or you do all-on-4 cases, there's a lot of crestotomy that we land up doing. First, to create a platform for the implants. And second, in the maxilla, you would be doing it because if the transition zone of the patient shows when the patient smiles, you need to move that because you don't want the junction of your prosthesis and the ridge to be visible when the patient smiles. So in these cases, when you do these crestotomies, what you land up doing is decreasing the depth of the soft tissue of the vestibule, which the patient is going to have. So once these implants were placed and sutures placed, and the crestotomy, that's the implants in position, you realize that you're left with no keratinized mucosa around these implants. And every time this lip moves, there is going to be a deflection of this soft tissue because there's no stable mucosa to support these implants. So typically what I follow, which is a fantastic technique to do, and it is time-tested and a proven technique, is you create a partial thickness pouch. You create a partial thickness flap dissection right up to the depth where you want the mucogingival junction to be relocated. At the depth of this pouch, you suture your alveolar mucosa to the apical periosteum of the pouch. You have connective tissue bed left behind on this ridge of the partial thickness dissection that you've done. At the base of this pouch, I like putting an epithelial strip. So this is a strip taken from the palate, which is not more than 1.5 to 2 millimeters wide, and it has only epithelium. So it is not deep into the connective tissue. It's a very thin strip, which is then sutured to the base of this connective tissue bed that is created. Why the strip? Because I feel that the strip acts as a fence which prevents the re-creeping back of your mucogingival junction over a period of time, and long-term stability is assured by this strip there. Now, I do not want to leave this as a free open bed because there is going to be otherwise closure and not enough of keratinized mucosa that you're going to get. So what I like placing in between the strip and my superficial border of this bed is a 3-dimensional collagen matrix. This is the mucograph that has been used. So you cut it to shape and you suture the mucograph on this entire connective tissue bed. This is a soft tissue substitute which will epithelize and is taken up by that connective tissue bed. And once the epithelium is formed, it forms a beautiful band of keratinized mucosa. So much of tissue is impossible to get from the patient's own palate. And these 3D collagen matrices are a fantastic substitute for that. So that's the matrix in place. That's how it looks 7 days post-operatively. That's healing at 21 days post-operatively. You can see the mucogingival junction is way down here now. And that's at 5 months post-operatively, where you see there was no keratinized mucosa, and now you have a stable mucogingival junction at the bottom here with a whole band of keratinized mucosa above that. And that's the final prosthesis follow-up at 3 years, where you see everything is stable once those implants are loaded. And that's the newly formed keratinized mucogingival junction with a good stable band of keratinized mucosa above it between that and the prosthesis. That was how we started off at baseline. And that's the radiograph at a 3 years follow-up. Why this? Because I want to see that the bone levels are maintained, and the bone levels are going to be maintained only if you have a stable soft tissue collar around that bone to support that bone level for the long-term success. Mr. Visaria came in with a similar problem. He was referred to me. These implants were placed by another dentist, and they saw that they were failing because of this soft tissue which was not present there. There was no band of keratinized mucosa. Again, very high attachment of the mucogingival junction. So the same procedure, a strip technique was done where the mucogingival junction was relocated, alveolar mucosa suture to the bottom of this bed, and then mucographed 3D collagen matrix was placed in between. And you see from here to here, that's the band of keratinized mucosa that you have. And then the dentist went ahead and placed the final restorations. And that's the stable band of keratinized mucosa. Now you do what you like. This keratinized mucosa is not going to move. It's there to stay for life because it's absolutely stable and a good band of keratinized mucosa. So please look into the keratinized mucosa before you go in and give your final restorations to these implant supported restorations, because if you do not have keratinized mucosa, you are creating a sure shot recipe for failure for those implants in the long term. Now, after soft tissue augmentation, let's look at a little bit of the hard tissue augmentation, which supposedly is the harder stuff that we do in implant dentistry. Whenever I talk about hard tissue augmentation, there are three musketeers. You cannot have one without the other. So what are we looking at? We're looking at bone grafts or bone substitutes. We're looking at barrier membranes, and we're looking at fixation devices. For any bone graft procedure to be successful, you need to use all of these three because each has a different role to play when you're talking about guided bone regeneration. So just to sum up the bone substitutes that we have available to us in practice, what do I want to look at when I look at a bone substitute and I'm using it to augment bone around my implants? I want a material which is going to, any bone substitute that you place is going to act either is going to be osteogenic in potential, is going to be osteoconductive, or is going to be osteoinductive. Osteogenic meaning that bone graft material has a potential to develop new bone by itself because it has all the bone morphogenic proteins present in the graft itself. An osteoinductive material is a material which will induce the surrounding bone to lay down bone morphogenic proteins to form new bone cells and form new bone. And an osteoconductive material is a material which is going to create a scaffold which will give the new bone enough time, which is 6 to 8 months, for new bone to form in any cavity that we are looking at, and maintain that space for that period of 6 to 9 months. So when I look at a bone augmentation procedure or a bone graft material, I want a material which is going to give me probably all three, but that is only available in autogenous bone. And the biggest problem with autogenous bone is, though it has all three properties, it resorbs very fast. So my go-to is to combine autogenous bone along with a slow resorbing material, which is osteoconductive, that is anorganic bovine bone mineral, because then I have the properties of the autogenous bone combined with a space maintenance property of the anorganic bovine bone mineral, which is going to keep the space maintained until that graft can be completely replaced by new bone which is formed. So that's the formula that I use and most people worldwide use for the choice of graft materials that I would want to place in the site. Coming on to membranes, I have a lot of people who ask me, do you always need to cover the graft with a membrane? Yes, you absolutely always need to cover the graft with a membrane, because what the barrier membrane is doing is, when you are augmenting bone, you want the bone forming cells to infiltrate that site, and you do not want the epithelium and the connective tissue cells from the soft tissue to invaginate that healing bone graft material. Because if that happens, the graft that you get or the bone that you get is going to be compromised. So the barrier membranes keeps the epithelial and the connective tissue cells. There's a cell exclusion due to these membranes of the unwanted cells in that healing site. When we talk about membranes, you have resorbable membranes. We refer to them as non-form stable membranes today, and non-resorbable membranes which are form stable. So when you actually shape the non-resorbable membranes, they will maintain the form for the period of 6 to 9 months. Resorbable collagen membranes have shown to be the most biocompatible membranes that we have available in any market today. When we talk about collagen membranes, there is a big difference in the collagen membranes that we use. I prefer using a native collagen membrane to a cross-linked collagen membrane for various reasons being, one is it's the most biocompatible compared, a native collagen membrane is much more biocompatible than a cross-linked collagen membrane. Also, it lets transvascularization happen from the periosteum of the soft tissue, because you're going to raise a full thickness flap when you doing bone augmentation. So the transvascularization from the periosteum also happens to the growing graft material, which depends on the blood supply that it gets. It's very elastic and very easy to use, especially in huge augmentations, which you'll see in cases that follow, how you need the elasticity of the membrane to actually compact your graft material in place. And it's a very, very biocompatible material. So I do not like using cross-linked collagen membranes. I always use native collagen membranes. When it comes to form-stable form-stable membranes, which I use only for vertical augmentations, when I want a 3D augmentation of the defect, it's the DPTFE titanium reinforced membranes, which are my go-to because they are proven to be one of the best membranes to be used. Now, whenever we are doing any kind of bone augmentation, there are 4 things that you need to keep absolutely in mind to make sure that you get bone regeneration of the graft that you're placing in place. That is called the PASS principle, PASS, and it can't be re-stressed more than enough as to how much each of these words plays a very important role. P stands for a primary wound closure. Whenever I'm placing a bone graft material or I'm doing any kind of guided bone regeneration, I have to make sure that my soft tissue completely covers that bone graft which I've placed underneath. So there has to be a passive primary wound closure by your soft tissue. So you need enough soft tissue and an absolutely passive elevation of the flap to close this bone graft material. The second is angiogenesis. Nothing can form without without blood. So you need to make sure that that graft is pumped with enough blood so that those blood cells will help incorporate that graft into the native bone in a much better way. And the quality of the bone that you get is much better when you have good angiogenesis. Third is space maintenance. The S stands for space maintenance. You need a graft material which is going to maintain the space for a period of 6 to 9 months, because that is the amount of time it's going to take for new bone to replace the bone graft material that is going to be put in place. And the last is the stability of the wound. When you place a bone graft, you have to cover it with a membrane which is stabilized by by tacks or fixation devices. Because if you have that membrane which is going to keep moving, the graft underneath is going to keep moving, and whatever fibers form, which are very weak when you have woven bone that is formed, these are going to keep breaking if you do not have stability to the graft material that you placed underneath. So these 4 things have to be kept very much in mind when you're doing any kind of bone augmentation procedures. So let's look at Robert, who came in with a type 2 socket. Another, I don't know why, am I blessed or not? I always get these cases which come from very challenging patients. Robert happens to be a dentist himself. Now, not the mother of a dentist, but a dentist himself. So he comes in with this one which had external root resorption, and it needed to be replaced and extracted. And he said, I want you to do it. My God, that really puts you under a lot of pressure when you're doing these kind of patients. So he had a little bit of soft tissue loss and a type 2 socket. Now, he was somebody I decided to go ahead. And so that's the various profiles. You see that the tooth is in a very different shape, a very narrow, thin tooth over there. Now, what I like to do is take a small pattern resin index before that. That helps me to reposition if I'm not doing something digitally or guided in these cases. So I have not included guided or digital platforms in this presentation because that becomes a different presentation altogether. So when we are doing everything analog, I use this pattern resin guide so that it helps me put back the shell of this tooth, which I'm going to use to make my provisional restoration, back in the exact same position as it was before we extracted the tooth. Once you do the extraction, the same protocols, you degranulate the socket. Now this I cannot do flapless. I have to raise a flap because look at the buccal defect that we have present on the buccal aspect of this tooth. So it's a type 2 socket which has minimal soft tissue loss, but a big bone loss on the buccal aspect. So after degranulation, I go ahead and place my implant in the ideal 3-dimensional position. Once that implant is placed, I use the shell, the buccal shell of his original tooth. So there's a lot of matching on that tooth over there when it comes to aesthetics of the provisional. Reposition that provisional back over here and then pick it up in a temporary cylinder with flowable composite, which is bonded. Now, once I do that, the threads of the implant, whenever I said before, I like to use a combination of autogenous bone with an organic bovine bone mineral. Now, when I need larger quantities of autogenous bone, my go-to site is the lateral ramus of the mandible. But in a site like this, where I do not need too much quantity of autogenous bone, I go to the anterior nasal spine, and you will see the bone scraper in the later cases. I harvest the bone with the bone scraper, and you get cortical shavings. Now, those cortical shavings of autogenous bone, I place as the first layer of my graft in contact with my implant surface. So I'm ensuring that the best quality of bone is on the surface of my implant when it matures. And then I layer it with a slow resorbing anorganic bovine bone mineral, which is going to let the resorption be slower till new bone forms in this entire cavity. You cover it with a native collagen membrane and you suture that back and you let that heal. Make sure that your provisionals are completely off occlusion when you're giving immediate provisionals. After 6 months, this is how this heals. Now, in a case like this, I would like to wait for a period of 5 to 6 months because you want the bone to have matured completely. Now you have your provisional, which has sculpted your interdental papillae, mesial and distal, and you have a nice profile of the buccal gingiva as well. And you go ahead, that's the occlusal view where you have a good emergence profile, and you go ahead and make your final crowns. That's the radiograph after placement of the final crowns. In his case, that is the final crowns in place. And a nice profile with good, thick, soft tissue on the buccal aspect of the gingiva. That's how we started. And that's the final restoration in place. Now, does this ensure that I have bone underneath? There's only a CBCT that can be the proof of the pudding in this case. So that was the preoperative where we had lost the entire buccal bone. That's the postoperative at 6 months. And that's the amount of bone that we have. In the cross-section, preoperatively, we had no buccal bone, as you saw in the clinical pictures. And that's the postoperative where you have a nice, thick buccal bone present. And that is why that soft tissue is also well supported with this on every aspect of the implant and all the cross sections. So this is what gives you surety that there is bone and that graft which you have put has got converted into bone which has been formed. And that's a smile at the end after we finished his case. Now, life is not easy and it gets tougher and tougher and tougher. Just when you felt, okay, now I know how to manage smaller defects, you are faced with huger defects that come into practice, and huge ridge defects like this, which have a vertical and a horizontal component, become even more challenging when it comes to function, aesthetics, and implant placements. So let's look at how we manage these huge defects. When it comes to ridge augmentations, form stable membranes, which are the titanium reinforced membranes, have known to be gold standards. But the biggest problem with non-resorbable membranes is membrane exposure. And believe me, you don't want to see a membrane exposure, because after all that you put the patient through and you've done a surgery which has gone very well, and you start seeing that membrane exposed, you know you're going to lose the graft underneath. You want to go more predictable in these cases. So my go-to when it comes to ridge augmentations is, if I want to augment a horizontal defect only in the horizontal direction and maybe 1 or 2 millimeters in the vertical direction, my go-to is a combination of autogenous bone with anorganic bovine bone mineral in a ratio of 1:1, of like 50:50, the same amount of both the materials, covered with a native collagen membrane, because those are the most beautiful membranes when it comes to biocompatibility with your soft tissues. And in a horizontal direction, that native collagen membrane, which resorbs over a period of time, is enough till your woven bone is formed and incorporated into this material. If I'm doing a vertical augmentation, which is more than 2 millimeters, then in that case, I need a membrane which is form stable. So my choice of graft material still remains the same. It's autogenous bone with anorganic bovine bone mineral, but covered with a form stable membrane. And of course, both the membranes are always stabilized with bone packs. For a combination of defect, like I said before, depends on how much vertical and how much horizontal. My choice of membrane will differ, but this graft, which is called the composite graft, autogenous in combination with anorganic bovine bone, is the choice of the graft material for these cases. So let's look at Lalita, who came in with no missing teeth from the canine to the first molar in this second quadrant. She had a broken down canine present here and a huge ridge defect, probably from an older extraction where the buccal bone was completely gone. And I needed to not only restore it, but also place implants there and bring back that contour of the buccal bone. So these are our preoperative images of the CVCT. So that was the tooth in question and missing 4, 5, and 6. So decided to do an immediate extraction placement for the canine and implant placements for the posterior 5 and the 6. So 1 implant in the canine, 1 implant in the 2-5, and 1 implant in the 2-6 region is what was placed. This was an immediate extraction placement. Now this happened to be like a type 3 socket. Though there was not too much of soft tissue loss, there was a huge bone loss over here. So what I decided to do again is do an augmentation for this implant on the buccal aspect. So this is the autogenous bone harvested from the side, from the anterior nasal spine. So that's the layer of autogenous bone placed well in contact with my implant surface, layered with anorganic bovine bone mineral to do a contour augmentation of this entire ridge. And also this defect over here, after decortication of the bone on the buccal aspect, was placed with composite graft, which was anorganic bovine bone mineral mixed with autogenous bone. And that's the graft in place. Now, very important in these cases is that primary wound closure. So you need to do a proper flap advancement over here with one periosteal release. I'm going to be talking on the flap advancement in the second last case that I'm discussing with you today. So once you have a flap which is advanced, because you need a passive primary closure, and then you go ahead and place a membrane on this, which is stabilized, and then a double layer closure is done in these cases, wherein you do a first layer of horizontal mattress sutures with a top layer of interrupted sutures to close this wound with a watertight seal so that nothing goes into this healing bone site that you have. And once that is done, that's how the patient comes back after a period of 6 months with stable soft tissues, good bone, good well-integrated implants, and that's the final prosthesis. And that's how the final prosthesis is. You see the buccal bone has also got a contour now with that big deficiency that we had on the buccal aspect. That's the occlusal view. And that's the CBCT 4 years post-loading. Absolutely stable bone levels, the implants in place, the prosthesis absolutely stable. And all implants had good buccal bone on the buccal aspect. Those are the various sections of those implants 4 years post-loading. And that's how she is with stable tissues and the prosthesis 4 years post-loading. This was a very interesting case. Harshada came in with a missing lateral incisor. And the biggest problem with missing lateral incisors are there's a huge compromise on the mesodistal dimension when you have a missing lateral incisor. And when you have a compromise in the mesodistal dimension that you have, recreating your papillae becomes a bigger challenge than placing that implant in that place. So she also had a horizontal defect. So that was the intraoral view of this side that we had. And she had a huge horizontal defect over here as well. So this was a case done a couple of years ago. And what I have done is for that horizontal defect, done a little bit of ridge expansion coupled with a contour augmentation on the outside of the ridge once the implant was placed. So we had 3 millimeters of the ridge to start with almost 7 millimeters of mesodistal dimension. So that's the osteotomy done for the ridge augmentation procedure, is to use these expansion osteotomes that you have. Today, I would just go ahead and do an osteodensification to place the implant here because that densifies my bone and also does not break the buccal cortical plate. Be careful when you're doing this because you can't do it if you have a D1 quality of bone. You need enough cancellous bone for this kind of an expansion. So once that was done, the implant is placed in the 3-dimensional position prosthetically. That's the implant in place. And now, is this going to be enough? No, I had a huge deficiency to start with here. So I am going to do a contour augmentation. So that's the membrane in place, an organic bovine bone mineral with autogenous bone mixed and placed on the outside of that buccal cortical plate, and membrane stabilized and a double layer closure. Am I going to provisionalize this implant? No, because I have placed it to augment it. It's not an implant which I want to immediately provisionalize. So I give the patient something like a Maryland bridge, which is supported by the central and the canine on the other side. And that's what is put in the patient's mouth on the day of the surgery. And that was the preoperative. And that's 6 months post GBR. And you see the nice convex contour of the bone from here to here. So at this point, I will go in and expose the implant and put a provisional restoration. I'm not going to go in and pick up the final because I still want to sculpt my soft tissues now. These are the CBCT images before we started where you had really thin ridges in the horizontal dimension. And that's the post-operative CBCT where you have the implant with good buccal bone on the buccal aspect. That's the provisional which was made for the patient, and you let the soft tissue sculpt into that provisional. And once that is ready, you have a nice soft tissue collar that is developed at second stage. You go ahead and place your final restorations for the patient in place. Now, if you see this, there's still a little bit of deficiency of this papilla here. What I would do in a case like this is, because she was studying abroad and she did not have time to wait back for me to sculpt the provisional further to bring this papilla down. So you make sure that you keep your contact point from the crest of the alveolar bone at a distance of 4.5 millimeters. If you do that, you should be sure that your papilla is going to creep into the space that you have created. So that was the final prosthesis in place. And I see her 10 years later. And you see how well this mesial papilla has also crept in. And you have an absolutely stable mesial and distal papilla with good bone and soft tissue on the buccal aspect. That's a radiograph, 10 years follow-up. And that's the beauty of the restoration, absolutely stable in place in an augmented site with the implant very stable. Coming on to the last few of the cases that I have to discuss today, and I hope you're going in good time. Reshma came in with the posterior maxilla again in the second quadrant, missing teeth from the canine backwards. Absolutely thin ridges, very thin bone, and we didn't have enough bone to place the implants. So my go-to is the sausage technique for these horizontal ridge augmentations, wherein once you expose the ridge, that's the ridge exposed. This is the decortication, which is done with a small round burr, the smallest round burr that you have. You put it with copious irrigation and you perforate the cortical plate. The moment your burr sinks, you are in cancellous bone and you will see profuse blood channels coming out through this. This decortication is ensuring enough of blood supply to the graft material that you're placing on this ridge. Once that is done, the membrane is stabilized, native collagen membrane, which is stabilized on the palatal aspect. And then when I need huge quantities of bone like this is autogenous cortical shavings harvested from the lateral ramus of the mandible with a bone scraper. That is mixed in with equal quantities with anorganic bovine bone mineral, which is Bio-Oss in this case. And you mix this to form a nice composite graft. And that graft is then placed on this entire ridge. Make sure that there is enough graft material. After I do this, I want to now tack my membrane. So when we spoke about the PASS, I needed stability to the graft material. One of the S was stability of the graft material. So what I typically do is I pull my membrane over. That's how the sausage technique by Dr. Istvan Urban is done. You tack the membrane on the distal aspect. Once you've tacked it on the distobuccal aspect, you raise the membrane and you still pack in further graft material into this side. You pack in graft material till you can make sure. Then I tack the mesial most aspect of my membrane and then lift the center part and still pack in graft material and put my last tack to support my material here. Once I've done that, I actually move and see nothing should move underneath this membrane. That makes sure that you have complete stability of your graft material. That's the sausage completely packed in place. And then flap elevation and primary closure. This is the first layer of horizontal mattress sutures. So you see, when I give the horizontal mattress suture, the passivity of the flap is so good that there's no gaping of these edges here. That's how passive your flap should be when you're closing it. And then interrupted sutures on top to close that wound. That's how you close it. That's immediate post-operatively, how it looked. And that's her CBCT's 6 years. Whenever I do a horizontal augmentation with a sausage technique, you need to wait for a period of 6 months. If it's a vertical augmentation, you need to wait for a period of 9 months. So we had an average bone width before we started off around 2.5 millimeters, and post-operatively, we had an average bone width of around 6 millimeters in all the areas. This is the post-operative, this is the pre-operative. So that's at re-entry. This was pre-augmentation, this was post-GBR, and you see the kind of bone quality that you have. Why do I like a mixture of the autogenous with this anorganic bovine bone? Because the quality of bone that you get is very close to native bone. When I do my osteotomies in grafted bone, what I want to see is nice bleeding osteotomies that ensures that my implant is going to be placed in absolutely stable, well-bleeding vital bone. And that's what you want to look at when you create your osteotomies. So that's the osteotomies in place, implants placed with fantastic primary stability, healing abutments placed on the implant, and flap closure. That's the post-operative after the implant's placed. And then you go in after 4 months and you pick up your impressions, and that's the final prosthesis in place. So horizontal augmentations are very predictably solved by the sausage technique, which uses a combination of these materials, and you get absolutely predictable results. Now let's look at one patient that I put up of a vertical augmentation. Ranjana came in, she had implants placed in her maxillary arch at some other practice, and she was told that she can't have fixed prosthesis in the mandibular arch, and she refused to wear anything removable in the mandibular arch. So this becomes a major problem for patients who want to function. She's a young lady who's 45 years of age. What do you do with such kind of defects? So we decided to also change our maxillary prosthesis and do a three-dimensional augmentation for the mandibular prosthesis. So both the sides of the mandible needed a vertical augmentation. That's the fourth quadrant. That's the third quadrant. That's the huge defect that we had in the third quadrant. So what do I do? Raise a full thickness flap. That's the third quadrant in position. Raise a full thickness flap on the posterior quadrant. Once you have exposed the bone, it's very important on the lingual aspect of the mandible and the posterior mandible to remain above the mylohyoid line when you raise your flap. You do not need to raise your flap to the floor of the mouth, because otherwise when you elevate this flap for closure, you're actually elevating the entire floor of the mouth and you're cutting the mylohyoid muscle attachment. So remain superior to the mylohyoid line. That's the mental foramen. Make sure that you identify that, because you want to exclude that from your grafted side. Once you have exposed and cleaned the bone surface, you decorticate the bone surface to create vascular channels. In this case, because I'm doing a vertical augmentation, I will always use a tie-reinforced DPTFE membrane. So that's the membrane tacked on the lingual aspect. Again, composite graft, autogenous and organic bovine bone mineral mixed, completely filled in the vertical defect, and the membrane tacked on the buccal aspect. Now, the biggest problem that I have with non-resorbable membranes is that they tend to expose because they are not biocompatible and the blood supply becomes a big issue. So I prefer always covering this grafted membrane with a native collagen membrane on top of it when I'm doing these huge vertical augmentations. Before doing that, I would elevate my flap to make sure that I have a release. So from the flap being attached here, we now have a flap which is raised to 15 millimeters. When you do this, there is one incision that you need to give from the mesial releasing incision to the distal aspect of your flap, which is in periosteum. It's a very superficial incision which just cuts the periosteum in one incision. After that, I do not do any kind of sharp dissection, because then I'm in the layers of the connective tissue, which has fibers which are elastic. So there is only blunt elevation of these elastic fibers, which is done in order to advance the flap and raise it so that I get a passive closure. So don't take your blade and keep going, cutting across those fibers, because then you're only cutting those muscle fibers, which is not going to help you in closure of your flap. So once you've done that elevation, I prefer covering that non-resorbable membrane with a native collagen membrane, because these are very biocompatible. Though these native collagen membranes are going to resorb over a period of time, they will resorb after a period of at least 6 weeks, till which time my bone graft underneath has started maturing and there is woven bone which is at least formed some lattice underneath, which remains in place over there. So that's the first layer closure with horizontal mattress suture. And that's the immediate post-operatively. That's how it looks 10 days post-operatively. Now, whenever I do augmentations like this, what am I looking for? I'm just keeping my fingers crossed, because you've done everything right and you do not want a membrane exposure, because an early exposure, you have to remove everything and need to degranulate everything and close the site. You've lost all that you've done. Same thing was done on the in the fourth quadrant. That's the fourth quadrant with the augmentation. Same procedure followed. That's the autogenous with the anorganic bovine bone mineral, composite graft in place with the membrane placed over it. And that's the release of the flaps, buccal and lingual. The same procedure followed on this side. So that was the pre-operative before I released the flap on the lingual aspect. There's hardly any advancement. Then I go ahead with my periosteal, and there's a mini vertical release incision which you give in the mesial tooth of the lingual flap. From that vertical release to the posterior part of my mandible, I go ahead and give a periosteal cut release incision above my mylohyoid attachment. Once I do that, again, I'm going to take a blunt instrument and do a blunt dissection or a blunt elevation of those elastic fibers to advance my flap. So from 2 millimeters, you have a flap advancement to up to 13 millimeters in this case. That's the native collagen membrane placed over the non-resorbable membrane. First layer of closure, second layer of closure, and that's how it was. Now, though the same, this is immediate post-operative after augmentation. Though the same procedure was followed in both the quadrants, I had a membrane exposure in the third quadrant. So that's the membrane exposure. Now, my aim when I have a membrane exposure, it's always smaller initially, is to keep it free of any kind of suppuration, pus, or infection. So you try and maintain that you see the patient more frequently and use chlorhexidine and clean that area. So keep it absolutely aseptic. And then at the end of around 6 weeks, the exposure really enlarged. And that's when I decided to go in, remove the membrane. So you remove the membrane, but you still have some soft bone which is formed over here. You don't need to remove that because it's not infected bone. I just cover it with a native collagen membrane at this point and close the whole site. Don't try to resuture an exposed membrane. It's never going to work. And then you wait. So I waited for 9 months. And that was the pre-operative ridge height that we had, 5.5 millimeters. And post-operatively, we had a ridge height in the third quadrant of an average of 12 millimeters, which is a very good ridge height to go in and place my implant. In the third quadrant, because of the membrane exposure, we did lose a little bit in the vertical dimension, but we still got enough in the horizontal and vertical to go in and place a shorter implant in the vertical direction there. So this was baseline. And this was at re-entry in both the quadrants. This because the membrane exposure, the collagen membrane was placed. And this is the non-reinforced membrane, which is removed at this point. And look at the bone peak that you have, absolutely in line with the bone that you had before you augmented. Re-entry in both the quadrants. That's the fourth quadrant. That's the third quadrant. I go ahead and place my implants. 6 implants were placed in this. And you see good bleeding bone there. That's the 6 implants placed for a full arch prosthesis. Multi-unit abutments placed. That was the before, that's post-augmentation, and that's post-implant placement. But because I knew that I had lost a little bit in the vertical, I decided to place an angulated implant over here. But then we had enough bone to place a shorter implant posteriorly for support. So we could manage to place 6 implants in the mandibular arch. So in this way, you can predictably augment vertical augmentations. But the only problem happens to be if you get a membrane exposure, you need to know how to tackle it and you need to advance it. The last case that I want to discuss with you all today is a patient who is very dear to me. Actually, she's known to me personally. And she was a young girl. Her mother came in when she was almost 22 years old. And she said that, it's a marriageable age in India. That's the time that you start looking out for a prospective husband. And she had a missing central incisor and lateral incisor, which was extracted when she was at the age of 16. Due to that extraction, and she was wearing this flipper partial denture, which she was wearing, there's a lot of pressure with this, and there was a complete resorption of those ridges. So wherever she went, she was told that she cannot get implants made. And the mother said that every time she smiles, that partial denture looks so anesthetic, and it's becoming a big problem. So when I saw her, this is the kind of ridges that she had. And I decided to go in and do a horizontal augmentation. These are her pre-operative CVCTs, where you look at the ridge in the 1-2 region, though there's some bone on the crestal, there's a huge defect in the major part of the buccal ridge, and a huge deficiency over here. In the tooth 2-1, also very narrow ridges to go in and place implants and get the ideal aesthetics. So plan to do a sausage technique for her. So that's the safety flap where you involve at least 2 teeth on either sides to give vertical release incisions. Now, whenever you're doing huge augmentations, you will need to give vertical release incisions because you need to advance your flap, which cannot be done without the vertical releases. So that's the vertical release, a full thickness flap raised. And that's the kind of deficiencies that we are looking at. So once the deficiencies were completely cleaned, you have nice clean bone. That's the 1-2 and the 2-1. I tack my membrane, native collagen membrane Bio-Gide, which is tacked on the buccal aspect, on the palatal aspect with bone tacks. That's the membrane in place on the palatal aspect. And then I have draped it over this tooth because I do not want to cut the membrane in between. So you get good sizes of the membrane, and the elasticity of this native collagen membranes lets you pull it over onto the buccal aspect. Here I need huge quantities of bone. So that's the lateral ramus, where you get cortical shavings with a disposable bone scraper like this. That's a safe scraper. And you have autogenous bone shavings with an organic bovine bone mineral that's placed on the decorticated bone on the buccal aspect. And then you pull over your membrane, pack the material so that there's absolute immobility of the graft material. With tacks, you have stabilized your entire graft material. And then you do your periostal release and blunt dissection of the fibers to advance your flap for an absolutely passive tension-free closure. That's an immediate post-operative. And then you wait for a good 6 months in horizontal augmentations like this. So that is the CVCT at baseline, where we had 4.9, 3.2, 1.9, 2.3 pre-operatively, and post-operatively we had average ridge width about 5.5 to 6 millimeters in that region, and in the 2-1 region as well. From a narrow ridge, this is the kind of bone augmentation ridges that we could get post GBR. So that's the time at 6 months, that is pre-operative. That is before re-entry to place my implants. So that's a full thickness flap which is raised. Pre-operative, you see the huge defects. Post-operatively, 2-1 region and 2-1-2 region. Look at the bleeding of this bone. The quality of the bone that you get with this composite graft is unmatchable. You have good bleeding bone, so I'm sure my implants are going into vital bone and not dead bone, which is grafted. That's my implants placed at the ideal prosthetic position apicocoronally. So even if you have some amount of threads exposed, it's fine at this stage, because I'm going to do a contour augmentation at this point. So in huge augmentations, you may need to do a second augmentation at the time of implant placement, but I'm going to provisionalize this because I have good primary stability. So that's the contour augmentation done at this point, covered with a membrane, immediate provisionals made in place. And that's how she walks out of the office on the day of implant placement surgery. Then you let this mature. And now, because I knew her, I was being really picky on this case. So I felt there was a little depression over here and I wanted to go ahead and sculpt the soft tissues. So same, create a pouch as close to the bone surface as possible in the connective tissue, harvest palatal graft from the subepithelial connective tissue graft from the palate, which is with a sling suture secured in the pouches that is created over here. It's a non-resorbable suture. And that's how she heals. This tooth also needed a crown, the 1-1, so that the midline was adjusted, which had deviated, and a provisional restoration was given on that. So that's with the provisionals in place. And then once you've recreated all of this is a case done more than 10 years back or 9 years ago. That time I used to do analog impressions. So that's customization of your impressions to recreate. So you take your provisionals, you attach your lab analogs to them, you create a putty index with the provisionals of the cervical part. To that, in the lab analog is in the putty index, you attach your impression post or impression copings, and you use flowable composite to pick up the soft tissue profile that you have created in the patient's mouth. And that's then put into the patient's mouth, and an open tray impression is picked up for that patient. And that's the final crowns in place, zirconia abutments with lithium disilicate crowns, which replicates the critical and the subcritical contour that you had in your provisional restorations. That's 1-2 and 2-1, the soft tissue sculpted. Nice buccal convexity of the bone. What do I want to see in my soft tissue cuff? I want to see this capillary network that shows how healthy that soft tissue is. That is pre-operatively, and that's when the final restorations were put in place. Implant-supported crowns in the 2-1 and 1-2, and tooth-supported restoration on the 1-1. Pre-operative, post-operative, nice convex contour of the alveolar bone. Pre-operative, post-operatively, that's how we finish this patient. And that's 9 years post-operatively with everything absolutely stable over there. That's how she had come in first. And that's how she walked out with her smile and everything in place. And that's her post-operative smile. So to sum up, what is it that we're looking at optimal implant restorations? We are looking at an absolutely thorough preoperative planning, not only of where your implant is going to go, but the prosthetic position and what bone and soft tissue you have to support those restorations for the long-term stability of the hard and soft tissues. The second is, when you plan your prosthesis, you need to plan with the end result in mind, because only then will your implant go in the right three-dimensional position. You position the implant shoulder submucosally in a three-dimensional position, and the long-term stability of your hard and soft tissues is going to be predictable and precise only and only when you have absolutely stable hard and soft tissues supporting that implants on a long-term basis. I thank each one of you for your kind attention and being present here today. It's been a wonderful experience for me to have you all here and share my clinical journey and things that I do in my practice. And of course, I also run an academy where we train clinicians to do hard and soft tissue augmentation. I thank Gaishlish once again for having me over for this webinar series. And I'm open to take questions which any of you have pertaining to the presentation or otherwise. Thank you, David. Thank you, Gaishlish Dental. Thank you, Gaishlish India, for this. Thank you so much.